Great. Welcome everyone to our first session of the Healthcare AI Forum in the year of 2025. And today we're going to welcome Felix Morales, who is the research specialist at the McCormick School of Engineering. He works in diverse projects such as building software to help activists make sense of massive amounts of scanned documents, building acute respiratory distress syndrome diagnostic app, and characterizing ARDS under recognition in hospitals across the US. Previously, he was the data scientist at Vizient after graduating from Northwestern University in Quantitative and Systems Biology program. He was mentored by Professor Nunes Amaral. His prior work at Northwestern spanned from elucidation of clinical trajectories of severe pneumonia patients using EHR data to automating the retrospective adjudication of ARDS through machine learning and natural language processing. So today he's going to tell us about addressing the under-recognition problem of acute respiratory distress syndrome, which is ARDS, in intensive care units. So now, without much further ado, let me turn the stage to Felix.
Thank you, Dr. Luo, for that introduction. I have to make the disclaimer that despite the talk having a subtitle of How Can Machine Learning Help, I'm here to start this talk not to talk about computers or algorithms. I'm not going to dive into artificial general intelligence or the latest buzzwords that you see every day in the media, because I'm here today to talk to you about people, talk to you about humans, to talk to you about how, even though for us human beings it's physically impossible to fly, we figure out a way to make machines that fly for us and carry us safely. Or to realize that what made us sick back in the day and used to kill us a lot were teeny tiny creatures that we couldn't even see with our own eyes, but we figured out a way to see them with microscopes and also a way to get rid of them by washing our hands. So if the life expectancy charts are any evidence of our cleverness, there you have it. But despite all of that, we're still the product of natural selection, and we still have instincts that frequently override our rational judgments and occasionally have us make mistakes. And so these were beautifully explained in the book Thinking Fast and Slow by the Nobel Prize winning psychologist Daniel Kahneman, where he cataloged a series of mental shortcuts and biases. But what I think it's more insightful about how this book started was how there was a framework to understand the ways we think. And basically, it was divided into two. First mode called fast thinking, the one we would use when we make automatic, quick, unconscious decisions like driving a car on an empty road or looking at the sky, seeing a cloud, and very automatically thinking that it looks like Einstein, like my dog, or like anything that you can think of. Or perhaps adding 2 plus 2, since we all learned pretty early on in school, what is that? So that we now reflexively just say 4, unless, of course, you want to be a jokester. But in that case, you would be engaging in the second form of thinking, which is the slow thinking mode. That's when you want to be more deliberate, more careful, more logical. When you want to park a car in a tight space, especially if you're trying to do it in parallel way, or realizing that you're just looking at random stuff in the sky, or when you're trying to perform operations like 17 times 24 that obviously you don't have stored anywhere in memory, but you probably know an algorithm or a procedure to do so. And I want you to hold on this idea of an algorithm or procedure. I think the key takeaway of this particular book is, well, many people get the takeaway that they want to blame their fast thinking, instinctive mode of thinking for all their mistakes, their biases, and their mental shortcuts. Because it's kind of true when you don't make a deliberate approach, or you don't use a deliberate approach to these things, or you don't slow down to realize that you probably need to gather more information to make a decision, that's where a lot of these mistakes happen. But I would say that's only half the story. Because if you think about it, we have done pretty well as a species and perhaps way too well. Let's see how this whole climate change situation pans out for us. But I would say it's a bit naive to think that having just a fast thinking mode has somehow been harmful for us. I mean, one thing I could say in pro fast thinking is it doesn't take too much energy, and actually you can't even turn it off. So you almost never feel that your brain is shut down. Um, and I mean, um, slow thinking mode, on the other hand, is very energy intensive. And I mean energy in a literal calorie sense. I'm not sure if you guys are aware of a study on judges on appeals courts. I think this study was in Israel, where cases that they had to decide at 11 a.m., um, they tended to approve those cases less frequently than cases that were decided at 9 a.m. So, assuming the methodological aspects of that paper were correct, one way to interpret that is that when you're hungrier, you're probably less able to engage on your slow thinking. And this has been borne out in other studies, not just this one. This idea that if you use your slow thinking, you're going to deplete yourself pretty quickly. But then the converse is also true. If you're depleted, if you're glucose depleted or hungry, you're less able to engage on your slow thinking and you will default on the fast. And so the first thing I want to say to that is that I really hope you guys had a good breakfast before joining this call, because it won't matter what I do. Probably I won't be able to hold your attention. Um, but the other result is pretty simple, right? Yes, we should use our slow thinking mode, but that's pretty energy intensive and it's pretty depleting. And this is a good explanation as to why when you see a 17 times 24, you probably want to reach out for a calculator or for your phone and just pull that out, even though you know there's a procedure you could use. Now, I can already tell that many of you would say, okay, you're just praising being lazy here. How about you just push through, always engage your slow thinking, and work hard for it? Well, I have something for you.
The monkey business illusion. Count how many times the
Oops, never mind.
players wearing white pass the ball. The correct answer is 16 passes. Did you spot the gorilla? For people who haven't seen or heard about a video like this before, about half miss the gorilla. If you knew about the gorilla, you probably saw it. But did you notice the curtain changing color or the player on the black team leaving the game? Let's rewind and watch it again. Here comes the gorilla, and there goes a player, and the curtain is changing from red to gold. When you're looking for a gorilla, you often miss other unexpected events. And that's the monkey business illusion.
So I will admit that when I first saw this video, I did see the gorilla, but that's not because of anything special on my part. I was trying to count the number of passes and I completely lost track. That essentially meant that my mental resources were freed up, and then I was able to see the gorilla. But once I saw the gorilla, I just couldn't focus on anything else because what on earth is a gorilla doing in a video like this? And of course, that made me miss the player leaving and then the curtain changing color. Hopefully, what you just experienced is that even when you're paying attention and engaging your slow thinking mode, you can still miss things. Now, luckily, this is a trivial scenario. You just missed players leaving a scene and a curtain changing color. But there are other scenarios, obviously, where missing things can have a bit more of a consequence. And that brings me to the modern intensive care unit, the area of the hospital where you can find the sickest patients. And you can see how complex the situation is here when any given patient is likely connected to some or maybe all of these machines. And furthermore, this patient is not being treated by one physician or one clinician. This patient is being treated by a team of clinicians, all of them communicating with each other to exchange a lot of information because at the end of the day, this team is making hundreds of clinical decisions day in and day out. Now, the slide is slightly misleading because it's only one patient here. In reality, this is a team that is splitting their attention among multiple patients, perhaps this complex. And so, in such a high pressure environment, and especially with the long hospital shifts that um, this clinical team probably engages in, it wouldn't be any surprise if any human being in this team would at some point have their ability to use slow thinking diminished. And then it wouldn't be surprising if this leads to mistakes, probably errors of omission or errors of commission. And I want to focus now on one particular example, real world example of these challenges in decision making, which is in the diagnosis and treatment of acute respiratory distress syndrome. And so briefly, ARDS for short is a condition where inflammation damages the lung tissue that usually that's due to pneumonia or sepsis that causes the capillaries inside the lungs to become more permeable. That leads to fluid building up in the lungs, what's called infiltrates. And that, of course, then leads to the lungs failing to do their job, which is to oxygenate the blood, that condition ultimately being called hypoxemia. It's not a rare condition. It affects 3 million patients worldwide every year. And then it has a mortality rate that oscillates between 35 to 45%. It depends on the severity. Now, because ARDS involves respiratory failure, the obvious treatment here is to place the patient in some sort of respiratory support. And most commonly, that takes the form of mechanical ventilation. But it turns out that in the early 2000s, there was this clinical trial called the ARDS network trial that found that using what's called low tidal volume ventilation would reduce mortality by 20 to 25%. And in the trial, that was strictly defined as using what's called less than 6.5 milliliters of air per kilogram of predicted body weight, which is a way to estimate the patient's weight based on the patient's height and its sex. So basically, the finding here was if clinicians avoid further damaging the lungs by not blowing a lot of air into them, they would be saving more lives than they currently save. But the issue here is that I'm talking to you about something that was found at least 20 years ago. So it should beg the question, why am I talking about this? I talk about condition, I talk about a treatment that saves lives. What's the problem here? Well, the short answer is that the treatment isn't used often enough. And so our collaborator, Curtis Wise, he was a critical care physician at Northwestern Memorial Hospital. He's now the director of the ICU at Endeavor Health. He looked into how low tidal volume was used at Northwestern Memorial Hospital. And so this was a study where patients that were admitted between June and December 2013 were accepted into the study. His team also retrospectively adjudicated that 362 of those recruited patients had ARDS at any point during their stay. And what the team found was that 70 out of those 362 patients received low tidal volume ventilation at any point. That's a full 1 in 5, or 19.3%. That begs the question, if low tidal volume ventilation is so effective, why is this number so low? Maybe we can think that clinicians don't really believe it works, even though there's evidence, or maybe that there's issues implementing the particular treatment. So Dr. Wise and his team explored that question further by asking the clinicians that took care of these patients about exactly that, their attitudes towards low tidal volume ventilation, and also if they perceived any potential barriers to use. And what they found was that, and I'm just going to focus on physicians from here on, the average physician would say that 92% of their ARDS patients needed low tidal volume ventilation. And then I'm not showing that here, but 80% of them would say that the evidence for low tidal volume ventilation was strong. So first question, do they don't like to use the treatment? Well, absolutely not. They seem to like it and they believe the evidence is strong. So maybe the problem is that they perceive barriers, right? Well, in excess of 85%, physicians would strongly agree with statements like, it was easy for me to obtain information to diagnose ARDS, easy for me to make sure that the patient is on low tidal volume ventilation, and easy for me to order it. So they don't seem to be aware of any barriers to the use of the treatment. And yet, among the patients that these physicians that answered the survey treated, only 7.4 of those patients received low tidal volume ventilation. So this is telling us that clinicians are not consciously choosing to avoid treatment, and they don't seem aware of issues implementing it. That's not the explanation for these low usage numbers. Something else has to be at play here, something that clinicians are not perceiving. And I could go on and on and on factors for this particular finding, but I want to focus on one that has plenty of evidence for its existence, and also I would argue is the most pressing issue, which is that ARDS often does go unrecognized by the clinical team. And you can imagine why I want to focus on this problem, because if you cannot see a problem, you can't fix it. And so very briefly, this was highlighted by a study done on 459 ICUs across 50 countries, the 5 continents, looking at, among other things, how often clinicians recognize ARDS. Basically by asking clinicians at the beginning and at the end of the study whether the patient had ARDS or not. And what you can see in this table is that, well, very logically, recognition rates did go up as the patients presented with a more severe case of ARDS, which obviously should make sense. But what's interesting is that even with severe ARDS cases, the recognition rate was not close to 90%. It was 78.5%. A full 21.5% of patients were still missed by the clinicians, even though they were being asked at the beginning of the study whether ARDS was a potential explanation for the patient coming in into the study. And of course, if patients presented with a mild episode of ARDS, the recognition rate was almost like a coin toss. So asking clinicians about ARDS, I mean, the end result of that paper is that yes, there's an under recognition problem, but the way this study was conducted was essentially asking clinicians about this, which can be time consuming, not to talk about that maybe it could introduce some observer effects. And so my former lab mate, Megan Beckel, who was in the medical scientist training program at Northwestern, she's now at Emory University. She developed a naive-Bayes approach to estimate the ARDS recognition rate simply using data that you can find in the electronic health record. And she first developed this tool on the patients from Northwestern Memorial, but then she was able to validate her results on the lung-safe data. And you can see in this table that her naive-Bayes model was able to very closely estimate the recognition rates that the lung-safe study found for patients in the lung-safe study. So basically, we have now a method that can allow us to estimate this recognition rate without having to survey clinicians, just using data you can easily find in the EHR system. But I believe that obviously the most important thing here is not so much that we were able to match the results from the lung-safe study, is more of what's actually going into making this model match the recognition rates from the lung-safe study. And so what's interesting is that that model only needed to know two things: the lowest standardized tidal volume that a patient received during a stay, and how relatively tall the patient is. And I think it's worth spending some time dissecting this result, because that will reveal something with which we started this talk. So let's spend some time dissecting this graph. So this graph is a boundary line. Above the line, the model would predict that the patient is less likely to be recognized. And below it, the model would predict that the patient is more likely to be recognized as having ARDS. And now we know from the ARDS network trial that, if a patient has ARDS, like this course of treatment here would be to prescribe lower standardized tidal volumes. So this boundary should make sense. Lower tidal volumes should correspond roughly with an ARDS case, and if it's higher tidal volumes, then it should be probably not ARDS. But what's interesting is that this line is actually sloping down. Taller patients are more likely to be recognized when the lowest tidal volume they received was close to 6 milliliters per kilogram of predicted body weight. And then for shorter patients, they're more likely to be recognized when the lowest tidal volume is around 8, which is very close to the edge that was prescribed by the ARDS network trial. So, but something here doesn't add up, because as I mentioned before, standardized tidal volumes already have to incorporate in some way, shape, or form the size of the patient. Notice that the units are milliliters per kilogram of predicted body weight. If you look at the formulas, predicted body weight already incorporates height. So if anything, that line should be flat. So why is height still a factor in ARDS recognition? We have to go back to the idea of heuristics happening in a complex environment such as the ICU. And I'm just going to read from the discussion section of the paper to shed light as to what's going on in here. Clinicians are likely using a heuristic when delivering tidal volumes, regardless of whether they recognize ARDS or not. A default tidal volume for most patients are average height or close to the average, and then with some adjustments for patients that are super tall or super short. That should make sense, right? Because if you're always using the same tidal volume as the patients grow taller, then obviously this ratio should be going down. So that makes sense with the encountered findings here. The other thing I would say is that when I have tried to plot distributions of tidal volumes for other hospitals, I don't get a distribution. I get peaks, usually at 400, 500, or 600 milliliters. So no wonder why, number one, there's been studies finding that female patients are less likely to be recognized than their male counterparts. If we accept the notion that on average, you could expect a female patient to be shorter than a male patient. But then that also sort of sheds light into why is it that there's a mismatch between what clinicians say in surveys and what they actually do. They probably think they're using low tidal volume ventilation through the heuristic, but as I've probably shown you here, it's not doing the trick for all patients. And so where am I going with all of this? Well, first things first, I'm not trying to point fingers here. Really, I'm showing all of this evidence just to point out that we're all human. We make mistakes. That's why, for example, I have to set alarms to make sure I don't sleep in. We use reminders. We rely on tools to simplify the complexities of our life. And so we all need help, really. And as I've hopefully shown you, and that was really the point of those studies, is to show that even highly trained professionals, like clinicians, are vulnerable to these mental shortcuts and errors of omission. And I mean that with a lot of sincerity, because there was this one neighbor that I had who hung out at my living room, who told me that he had been in the Marine Corps and he had been deployed in the Middle East and everything, but he was now in med school. And he said that whatever level of stress he was feeling in med school was orders of magnitude higher than whatever he experienced in the military. Now, I don't know how much to believe that N of one anecdote, but that already tells me a lot about what it takes to become a medical professional. It really takes something special. So I do mean it. But at the end of the day, medical professionals are also human. And especially those who devote themselves to the pulmonary and critical care specialty, I think being human, you deserve all the help that we can give you, since the decisions made in the ICU tend to be life and death. And so the question here is, what can we do for you? Well, one solution here is for me to break the fourth wall here and just confess that I've been talking about humans, but really I was eagerly trying to talk about just bowing down to our AI overlords, because AI will have this super intelligence that doesn't make fast or slow thinking mistakes, right? Or maybe not. Maybe not so fast. Some of you may be familiar with this study from Nature Machine Intelligence. It was right around when the pandemic was going in full force, excuse me. At that time, there were plenty of papers coming out that claimed to use some sort of convolutional neural network to accurately predict COVID-19 simply based on radiology images. And then came along the study where the authors were trying to reproduce those results. And what they found was that almost all of the data sets used to train those models had stuff in those images that tended to be more prevalent on the COVID-19 positive images than on the COVID-19 negative. And that stuff had nothing to do with pathology, or rather artifacts. And so, for example, you see, hopefully you can see in this image that there seems to be hooks on right on the area of the shoulder. And apparently these artifacts tended to be more prevalent on the COVID-19 positive than on the negative. In a scenario like that, guess what AI models are going to do? So in this study, the authors use what's called saliency maps. It's just a way to show you which pixels are being looked at strongly by the AI models to come up with their predictions. And you can see that the models tended to pay heavy attention to the area of the shoulder, not the area of the lungs, perhaps also in the lower corner here. This over here is the diaphragm. And of course, sometimes the models would actually take a look into the lung area here. But I guess the question is, shouldn't the models only be looking at the thoracic area instead of using artifacts to come up with their predictions? Now, I want to clarify something. The title of my slide is AI Gone Wrong. But really, this is just another example of a human mistakes because AI here did what it had to do. Essentially, fast thinking on steroids. You give it input pixels, you give it labels, and it will find whatever pattern it needs to do so that the mapping between input and output is as error-free as possible. It doesn't care about which pattern it uses for that purpose, right? The problem here came from how humans failed to use their slow thinking in sourcing and pre-processing the data before they fed it to the machine. So let's try this again. What can we do here to help the ARDS under recognition problem? Well, I've spent some time in this talk talking about humans because I do believe that our goal shouldn't be to replace them or compete with human thinking. I do believe that it's either to complement our strengths, which we have many, even though I've spent time on the other side of the coin there. But of course, one good use of AI and any computational technique for that matter would be to ameliorate some of our shortcomings. And I want to come back now to the concept of 17 times 24, because hopefully you all know that if you take a piece of paper and a pencil or a pen, you can work out the answer to that multiplication. And I'm just showing you here how I learned to do this in school. What's interesting about this is that humans before us spent a good chunk of their slow thinking energy to give us a way to compute the multiplication without having to come back to the concept of multiplying, which would have you do 17 24 times, add up 17 24 times, or vice versa. You just have to follow this procedure and you don't have to think too much about it, and you will have your answer. But I bet that many of you still feel some resistance to doing that because you know that you can just pull out your phone and type the numbers and there you have it, right? Almost no mental energy spent on this because there was yet another set of human beings before us who programmed the machines to carry out that algorithm for us. So we have to spend almost zero energy doing this. This is almost a fast thinking task now, when at the beginning of our existence, this was probably a slow thinking task. Well, turns out that very fine members of the medical profession have spent decades refining a definition of what ARDS is versus what it's not. The latest iteration of which is called the Berlin definition, which is essentially an algorithm or a series of criteria that must be true for a patient to be diagnosed as having ARDS. And so what we're proposing here is to do exactly that, automate the implementation of a guideline because it is amenable to automation. Instead of coming up with features to predict an ARDS label and then have to start playing games with interpretability, we're proposing here to commit this particular algorithm to a computer so that physicians stop needing to spend their slow thinking energy, which is so precious and it's already spread thin, implementing this algorithm, which hopefully you will see in the following slides. It's particularly complicated for a human brain to do reliably in the middle of many things going on. So remembering that ARDS is a condition where you have inflammatory injury, lung injury, causing both lungs to fill up with fluid, and that results in the patients becoming hypoxemic. Well, the Berlin definition is exactly that, but it can be implemented backwards. First thing is to ensure that the patient is indeed hypoxemic, and that's actually easy to do if you have access to a value called the PF ratio. And anytime that ratio drops to 300 millimeters of mercury or below, you know the patient is hypoxemic. So that first step is particularly easy. What's more difficult are the next two steps. So once you know that the patient is hypoxemic, you then have to ascertain that the patient has bilateral infiltrates or fluid in both lungs. And this is evaluated through chest radiographs and you can either look at directly at an image or read the radiology report for that. One thing I have to mention is that these two criteria are, from the data perspective, are easy in the sense that if a patient is intubated, a PF ratio should be collected every day and a chest radiograph should be collected every day. The only issue is that on the second step, it's been shown that you could have 2 or 3 clinicians looking at a chest image, and they probably wouldn't agree with each other as to whether that's positive for bilateral infiltrates. And so this step has been shown to have some reliability problems, and I'll later on mention how we decided to address that. And then finally, you ensure that the reason the patient has the previous two criteria fulfilled is that there's indeed an inflammatory lung injury. And so for that, you look into attending physician notes to check for risk factors like pneumonia, sepsis, aspiration, so on and so forth. One last thing I'll mention about this criteria is that there's timings involved with this. Hypoxemia and bilateral infiltrates, if they're both positive, should be happening within 48 hours of each other. And once you fulfill the first two, then there should be a note mentioning a risk factor within 7 days of the previous 2 steps. And then finally, I should mention that there's a 3.1 or 3.A criteria, which is sometimes you won't be able to find a risk factor. And so what has to be done here is to rule out cardiac failure or heart failure as the reason the patient's having fluid in both lungs. I'm not going to go into too much detail as to how we implemented that, but I'll be happy to discuss that at the end of the talk. But okay, so first thing we did here was to automate the adjudication of bilateral infiltrates through a machine learning model. So how did we go about developing it? So for training, we had almost 12,000 chest imaging reports from Hospital A. This is essentially the 2013 cohort from Northwestern Memorial. We had 6,000 from the 2013 cohort and then 6,000 from another cohort in 2016. And then we also had available 600 reports from Hospital B at another time frame. So we essentially had 2 hospitals, 3 different time frames for a total of 1,600 admissions and 12,500 reports. That was used for training. For testing, we used 975 reports from Mimic 3. We didn't use Mimic 4 because Mimic 4 didn't seem to have available all the text data that we needed to properly test our procedures here. And so all of these reports were labeled by the same critical care physician as yes or no for bilateral infiltrates. So this was effectively a binary classification problem. And you might remember that I mentioned an inter-rater reliability issue. Well, in the previous studies that I mentioned, our collaborator Curtis Wise was retrospectively adjudicating ARDS. He encountered the inter-rater reliability problem, and to try to mitigate it, he came up with this inclusion and exclusion language. Basically, if you find any of the key phrases in the inclusion language and in the reports, it should be adjudicated as yes. And if you found any of the words or key phrases in the reports, then it should be adjudicated as no. And so this was one way we addressed the inter-rater reliability issue. And so we definitely made sure to keep phrases that had these keywords, especially in the findings and conclusion sections of the reports, extract those key phrases, take away stop words, and basically just use a simple bag of words approach to represent that text as token counts. And ultimately, this is what we fed to the machine learning models. Now I'm going to skip that we indeed did some model selection. I'm just going to report the result that we found XGBoost to have the best combination of performance, probability calibration, which was a very important aspect for us, and interpretability. But what we then did after finding that was to train an XGBoost classifier on those 12,000 reports and then implement it on the 975 labeled reports from 100 mimic patients. And what you can see here is that this model did pretty well in discriminating between positive and negative reports from mimic 3 with a mean area under the ROC curve of 0.88. But you can also see that this model learned to use the token edema quite strongly as a feature. And just to go through what this graph means, these dots in blue mean that these are reports that did not have the word edema at all in the text. And so what the model would do in that case is to decrease the baseline probability of the report being consistent with bilateral infiltrates. But when the word edema was present at particular counts, depending on what other words were present, the model would increase the probability of that report being consistent with bilateral infiltrates. And so that's how you interpret this particular graph. And you can see here that there's other words that were also present in the inclusion and exclusion language. Now, in the wild, this model wouldn't just be spitting out probabilities, although that's one thing we really wanted to do, but in the wild, it would probably be used to do binary decisions, yes or no, bilateral infiltrates. And so what we did here was to binarize those probabilities using a cutoff that would maximize the F1 score. And you can see that by using that cutoff, we achieved a sensitivity of 77% in adjudicating the reports with almost a 14 positive rate in adjudicating reports from MIMIC 3. One caveat I'll do here is that we only chose that cutoff to be able to show you a confusion matrix. If the models were to be used in real life, we would probably use a bit more principled set of criteria to choose a cutoff. In particular, there's a framework called the Clinical Utility Framework, but we decided to leave that for further studies. That was for the bilateral infiltrates. Now we go on to the adjudication of risk factors. We very quickly learned that we can only use machine learning in a sensible way for pneumonia. And so that's what I will describe in detail. Now, for this particular task, we didn't have as much data as we had for the bilateral infiltrates task. We had 955 notes from Hospital A that were labeled for pneumonia. And then we tested whatever model we built on 790 notes that were labeled for pneumonia on MIMIC 3. And then for this task, we also did not have available a set of inclusion and exclusion keywords. And so what we did here was we did this for every risk factor. We would use a regular expression approach to capture keywords associated with pneumonia. And in this particular example, it's particularly easy. It's just pneumonia. Once we extracted that pneumonia keyword, we would extend a 100-character before and a 100-character after window and extract that snippet of text. And to that snippet of text, apply the bag of words approach to represent that snippet as token counts. And again, that's what we would ultimately feed the machine learning models. And again, we would train the XGBoost model with those particular token counts and implement it on 955 pneumonia notes 790 notes from MIMIC patients. And you can see that this model also did okay in discriminating between yes or no for pneumonia in MIMIC 3 clinical notes with a mean area under the ROC curve of 0.86. But what's interesting is that this model learned to use the word pneumonia quite heavily. If it didn't find it, it really decreased the probability of that note saying that the patient had pneumonia. But if it did find it, it increased it by a lot. And so again, we binarized the probabilities here using a cutoff that would maximize the F1 score. And we got a sensitivity of 75% and a false positive rate of 8% in adjudicating pneumonia on notes from MIMIC3. Now, ARDS actually has many other risk factors aside from pneumonia. And for those, we use the regular expression approach. But I'm not going to spend time showing you all those confusion matrices except for a very important risk factor, which is sepsis. It's either the top risk factor for ARDS or at least it's in second place. So you can see here that we developed a regular expression pattern to capture sepsis on Hospital A, but that also worked pretty well in capturing sepsis on MIMIC 3 notes with a false positive rate of 2%. And so we finally stitched together the models, their regular expression patterns, and other aspects of the process that are simple if then else statements to diagnose a set of MIMIC patients. And so we had available 100 MIMIC patients, 100 MIMIC admissions, which our critical care physician, which we consider the ground truth, adjudicated as 31 of those having had ARDS. A first point of comparison here is that if you looked at the documentation of those MIMIC 3 patients, it only seemed that 7 of those admissions were recognized or had any documentation that their treating physician recognized ARDS. So that's a full 22% sensitivity, pretty close to the 19% I showed in the first study. Now, that's not a good enough of a baseline because these are physicians that are in the heat of the moment. They're doing their job. How about we get a baseline from a physician that has completed training in internal medicine, not yet on critical care medicine, but despite all of that, has plenty of time to adjudicate these reports and see how this physician does against our ground truth. And you can see that this physician adjudicated or had a sensitivity of 84%, which is interesting because then we implemented our pipeline, which completed this adjudication pretty quickly in less than a second, and it still found 3 more cases than the less experienced physician. So that's a sensitivity of almost 93%. And what's great about this is that you have an automatic process that can adjudicate ARDS, a bit more sensitive than a trained physician who had plenty of time, which is a very important result considering that the problem we're trying to tackle here is ARDS recognition. Although, of course, our pipeline had a false positive rate of 19%. And so to wrap this up, yes, we're only human. We need all the help that we can get to deal with our human shortcomings, but there have been humans before us that left us with ways to solve our current problems more easily. And what we have here, or we're sitting on right now, is a procedure to diagnose ARDS, which is a bit complicated to implement in real time, but it can be automated. And as I've hopefully shown you, computational techniques to learn from data, so artificial intelligence, can definitely help us in automating processes like these, which would be very complicated to do otherwise because there are still some complexities to this particular algorithm. And what we've shown you today is a computational pipeline that successfully automates, at the very least, a retrospective adjudication of ARDS. And as far as we know, we're the first group to report on a pipeline like this that applies to any intubated ICU patient. And I say that because previous studies usually use cohorts of patients for which they either had already COVID or some sort of risk factor. So that step of having to look into risk factors is pretty much already done for them. Or when they do implement all of the steps of the Berlin definition, it's tested within their own hospital. So another strength that we believe our study has is implementing this on a widely available data set of Mimic3. All you really need to do is sign a data use agreement so that you can access that data and check how our results line up with yours. Now, we're currently implementing that on data from multiple centers across the US. We're using this pipeline to quickly adjudicate ARDS at scale on data from multiple centers across the US, but I think we ultimately aim to translate this work into real-time usage. And so we welcome your suggestions, your feedback, your collaboration, or your questions too. And before I wrap this up, I want to thank Curtis Weiss. This work did get all started with his leadership, and I can't say enough of the fact that he's the guy who reviewed almost 20,000 reports and notes himself, and then he pretty much labeled those reports. I also want to thank Megan Beckel, who early on in my time at Amaral Lab actually onboarded me into this project. Lei Hong Shu, a PhD student in our lab who did most of the initial lift in subsetting those mimic encounters to the subset of 100 patients. And obviously Luis Nunes Amaral for his mentorship, his feedback, and encouragement. And with that, I'll open it up for Q&A. Thank you for your attention.
That's great. Thank you, Felix, for the great presentation. So we do have a couple questions from the Q&A session, so I'm going to just read it out so that you can hear and answer them one by one.
Okay.
So one of the question is, which machine learning software and vendor did you use?
Right. So that's open source, right? We use essentially logistic regression through the scikit-learn implementation. We use random forest through the scikit-learn implementation, then also the decision tree, scikit-learn implementation, and the XGBoost package. And so all of that is open source, is not necessarily proprietary. And I guess I could use that as a plug to say that once this study is finally published, the repository would be made available to all of you. So the title of the paper is open source. So hopefully that would help in that particular regard.
Great. So I also see that Abel has raised his hand. So Abel, are you able to unmute yourself and speak up?
Not sure if you can.
Abel, are you able to unmute yourself?
Maybe not.
Well, so in the time that Abel is trying to unmute himself, so I can read the next question. So, have there been studies looking at the structured versus unstructured data as source for machine learning? For example, does structured data, for example, discrete diagnosis, medications, labs perform better, or do full clinical notes, which may have more context, work better, particularly for reducing false positives?
That's an excellent question. So my understanding is if we could, maybe some part of that question is, couldn't we just use particular diagnoses or ancillary diagnoses, maybe perhaps ICD-10 codes for doing these kinds of determinations? I'll be honest there that I'm not too sure about that particular aspect, and if I have to vaguely remember studies going to that particular question, is that you're always going to run against, well, were those conditions coded in the EHR? So that's one point against using particular billing codes. I guess the other aspect, and you're going into this aspect of reducing false positives. One thing we did notice, and I think I can show that here, is that when we trained these models to do the adjudications, they tended, so one thing we really like to look into is calibration plots. Essentially, just to give an example, if a weather forecast is going to say that there's 80% chance of raining, it better be the case that out of all the times that the forecast said that, 80% of the time actually rained. So that's the concept of calibration. We were aiming for the same thing in our models, but when we implemented those on Mimic 3, we found that as the probabilities that were coming out of the model were closer to 100%, the model would become a bit more overconfident. Well, we were suspecting this was not an issue of our particular implementation, but how the labels were coming to be. And so we compared the probabilities of the model against how our internal medicine physician and our critical care physician agreed with each other with the labels. And you can see here that as the models or as the model became more confident, the humans became more unreliable themselves. So we were suspecting that these false positives probably come mostly through the fact that humans are already starting to disagree with each other. Um, and so if anything, we were concluding that our model is going to be as reliable as it can be when it's telling you no. But when it's telling you yes, it's mostly a signal for you to pay attention and have a second look at what's going on. So that's the note on the false positive aspect. But I know that doesn't fully address the question. I'll be happy to answer that further through the email.
That's cool. So next question is, can you speak to some of the other practical implementation considerations? Where do those notifications need to sit? For example,
Mm-hmm.
within EHR, within nurse alarm, communication system?
Yep.
Do any of the Northwestern facilities currently use this today?
So when I started this project, I thought, oh yeah, that the easy solution here would be to notify, but we all know about alert fatigue. One aspect that my lab investigated some time ago was what tends to lead to increase the usage of an innovation. So a new tool or a new technique that perhaps only one or two of the physicians or within the clinical team use. What seemed to work, or what was found in that study, is that it's actually not that surprising, although it really provided good evidence and good theory behind it, which is the whole concept of word of mouth. It was a study where only two physicians knew about a new assay. I think it's called the procalcitonin assay to figure out if patients had some sort of infectious process going on as an explanation for their inflammation. And those results would come really quickly. It would only be like 2 or 3 hours for you to know that probably the best course of action was empirical antibiotics, as compared to the gold standard, which is microbial culture, which can take days. And the interesting result there is that at the beginning, only those two physicians would use it, but given enough time, enough physicians were starting to pick up on the usage of that particular tool. But that only came through the trust of your colleagues, seeing them using that particular tool and perhaps seeing that it actually works for them, or at least doesn't really hurt them or anything like that. And so one aspect for an implementation like this would be to have an advocate of a tool like this. But then even before we go to that stage, we have to consider whether we actually want to alert physicians or whether this is something that should be run perhaps overnight so that it's information available in the rounds rather than alerting physicians while they're in the middle of something else.
That's cool. So there is another question coming in. Um, did you try using neural networks?
No, it was a bit of a summary decision on our part because number one, obviously early on we said let's go simple. We would use just traditional machine learning models, but then as soon as it was becoming obvious that it was working, and we tried to interrogate it in many ways, shapes, and forms, and it was um, working better than expected. So we thought that going then the neural network route would have been a bit more of overkill.
Cool. So there is another question which is also related to the question that I wanted to ask. So where clinicians from developing world and also low resource settings can learn um, ML for this type of work?
Yeah, a lot of this work is predicated on an EHR system that reliably collects this data because if the data is not there, the system will not tell you that there's ARDS present, right? The data has to be there first and foremost, and then once it's there, it would tell you that the patient has ARDS. And so I feel for that question. I'm not too sure. It will, since it highly depends on the availability of data, I would say that that's going to be one limitation of a pipeline like this one. Now, in terms of learning ML, the luck here would be that one thing we're really aiming to do here is number one, to make the repository available to all. Then we're taking pains to make the code, as readable and as easy to understand as possible. So once we publish this, hopefully there will be well-documented code base, but also perhaps tutorials for people to essentially implement this and test them themselves.
That's cool. So we have answered all the questions in the Q&A sessions. I also wanted to turn to our panelists, David, Abel. Do you have questions from your side?
Yeah, and one thing, and thank you, Felix, for this great talk. Appreciate it very much. And sorry for the technical difficulties with unmuting there. I was wondering, well, one comment, the Mimic 4 data set, Northwestern now participates in contributing to that.
Mm-hmm.
And I'm not sure the best way to put a link in. Is it to put in the Q&A or is it in the chat for links?
Probably chat would be best and chat to everyone.
Oh,
Okay,
we got echoes there. We got attending physician notes, all that stuff.
great. Yeah, and one the other question was, you listed your sort of investigators. Do you currently plan to is this ongoing work that you plan to do within the Northwestern system, or are you working with some of the folks who are currently active? Because there's quite an active pulmonary critical care sort of research operation in the
Mm-hmm.
machine learning space. I was just curious about your plans there.
Yeah, no, I guess what I had in mind was that since our collaborator is mostly working from Endeavor Health, that would be perhaps the first point of either implementation or testing for implementation science research there. But I'm completely open to collaborations with the Northwestern systems because that's essentially where all of this effort was born. So it would be a logical thing to reach out. So I guess part of the reason for me to give this presentation is to reach out and start to get to know people on the space.
That's great. Any further questions from the panelists?
So is there a way for me to share the studies that I talked about in the chat? Because I see hosts and panelists, but I'm not sure if that goes to the rest of the people.
You can change to host and panelists to everyone. So if you are
Where's
able to
the
do
everyone
that,
here?
then you can share the link and then to everyone.
I'll just put it. I cannot see it, so I'll just put it there. And if any of
Okay.
you can do it, then that's fine.
Yeah. So I'm just gonna copy that and then relay that to everyone. Okay. Oops. Okay, done.
There you go.
So I'm now seeing further questions. So, and I see we are almost on top of the hour. So thank you again, Felix, for the presentation. And also thank you everyone for tuning in. I also wanted to take this time to let people know that this year we are doing a transition from Northwestern medicine only to nationwide consortium. And we have invited universities to feature in one of the subsequent sessions. And in particular, in our February session, we will feature colleagues and friends from Wisconsin Medicine. So stay tuned. And with that, thank you everyone again, and we'll meet again in 1 month.